As best we can, guys. So we left off on PA mandibular body. Did we talk about this one? Am I past this?
No.
Yes or no?
Actually, yeah.
Yes, we did.
We're on the axial now.
Yeah, you are.
Is that where we left off? Right here? Okay. So PA axial mandibular body, guys. Star of our show, of course, the mandibular body, not the rami anymore. That was the previous position we talked about. So when we're doing the PA axial mandibular body, of course, we're utilizing an angulation to elongate that body section, that being the horizontal portion of the mandible. We are going to have the patient preferably seated upright, not prone like you see in the picture there. That would not be ideal. Also very uncomfortable if their chin or their mandible is dislocated. I wouldn't be putting them on their chin like that. That probably not going to be a good time. Or put them in the Panorex. That'd probably be the easiest way to do that. Now, how are we going to position? Nose and chin will be touching the bucky. And that's a little bit different than how we did the rami, which is nose and forehead. We're going to have that interior surface of the mandibular symphysis or the tip of the chin parallel to the IR plane. AML, it says nearly perpendicular, but not quite 100% perpendicular, just the way we are putting those body parts on the bucky. But as perpendicular as possible, and the MSP centered and perpendicular to the IR plane. Now, as you can see, before we go to the next slide, is once again going to be a 30-degree cephalic angle. When we're doing our mandibular axial views, we're utilizing the cephalic angle as opposed to that caudad like we did for the Caldwells. A little bit different to elongate that portion of the jaw. It's giving me anxiety when it's blinking. I hate when stuff doesn't work when it's supposed to. This happens to me during my speech on Friday. I'm going to be like, are you people, come fix this right now or I'm not continuing. Y'all want to make me drive up here and give me bad equipment? Y'all better fix this.
You're gonna have to read from
Huh?
They'd be like, we're not here to tell us that.
They said, okay, since you're from San Jack, we'll take it.
By the way, it's likely what's going on is a driver issue with the computer. I said the driver's updated. So,
No, you can't chop either.
someone didn't apply the updates properly.
And we come back and be like, door's closed.
All right, guys, and once this picture comes back up, you'll see there is a nice 30-degree cephalic angle. There you go. Cephalic angle between the TMJs. That's going to be our centering point between the TMJs. If that's correct, it should be exiting around that campion area, as you can see by the white screen. Of course, make sure you utilize that good tight collimation again, guys. One of the mistakes people make on these mandibles, again, if we're talking about certain techs at the hospital, is they leave it wide open. We do not want that. By the way, I had a fun time talking to Negri yesterday, Charo.
Oh, he did?
I did.
So you said it.
We don't want to leave it wide open, guys. I made him turn beet red. It's going to exit around the campion area, yes. It doesn't tell you that, but that's about what's going to exit if you're between the TMJs. So make sure you have that nice tight collimation guide, at least 8 by 10. And once again, you just want to see the area from the TMJs down to the tip of the chin. TMJs down to the tip of the chin. Make sure it's just slightly below the chin.
Can you lock the string or something?
Yeah, that's a good idea. I don't know if that's going to work, but
No.
What did you say?
actually, no, it's not the projector. It's not
Yeah.
gonna work. That was a good idea, though. It gave me some hope for a second.
Structures.
The what now?
You said the TMJ and what?
The mandibular symphysis.
You just don't want to send it to PowerPoint.
I don't.
Just the last
He
one.
said, no, I
Do
don't.
better.
Just the last
Say
one.
that.
Be able to look
He
at
said,
it.
no, I don't.
Without the information.
These nice fancy smartphones, you take pictures.
And going
I
so
hope this
fast.
doesn't happen.
And
That's
it's
still
in-
recording.
And it's in the book, right?
It's in the book.
Thanks, Shanika.
Hey, I mean, y'all know you're gonna say
All
that.
right, guys.
Lecture
Let's hop
without
over
the
here. What are we looking at?
Just lecture without
Mandibular
the
body, it's in the name. We're elongating the mandibular body specifically. And we're also utilizing a good look of the TMJs to check that dislocation. Evaluation criteria, of course, we want the entire mandible. When I say entire mandible, that is the condyloid processes down to the mentum. TMJ area down to the mentum.
I was going faster.
Let's
Can we
see.
just really stop? Like, this is making my head hurt.
So the regular mandibular body, we don't see it.
Take the picture, take the picture.
don't see the TMG?
The regular one you should still, yeah. Now the book picture is going to show it cut off, but per the criteria you should still see TMJs. When we talk about mandible X-rays, we're always, I mean you are, but you should still have enough opening to see TMJs. When we talk about mandible, every mandible X-ray should show the entire mandible, and that's from the condyloid processes down to the mentum, no matter what you're doing. So some of the pictures in the book, once again, will show that cut off. It's incorrect. It does say on the slides in your book as well to include the entire mandible, even though they're cutting those
So
processes
green
off.
light and white.
For both, yeah. All right.
It's just elongated.
It's just elongating the body. We're stretching it. We're stretching it out. We go fast. We're stretching it out. Okay, guys. So axiolateral and axiolateral oblique mandible. Probably the one people hate the most, especially in lab. I'm sure y'all just adore doing this X-ray in lab. But a very important X-ray to really help us get a good oblique view of the mandible as well as that TMJ joint to check for dislocation. There are 3 methods to this X-ray that we're going to learn. It all depends on what part of the mandible you want to focus upon. So first off, as you can see in your books, that a couple of you have opened, we are going to preferably have the patient sitting upright once again. And this X-ray is going to utilize a little bit of rotation and tilt to get the head correct position and some angulation depending on what we are looking at. The main goal of this X-ray, which is that blue box there, is to place the desired portion parallel with the IR. So, excuse me, we're going to look at the entire mandible, the ramus, or the body in particular. Depending on that, we're going to make slight adjustments to the positioning and or angulation of this X-ray. Now, me personally, I like to just do a general survey. Did y'all learn a general survey in lab? Or did y'all learn like
We
the
did.
ramus body? I did the survey.
Yeah.
I prefer the survey because general survey, what's that mean? It's a survey of the entire mandible. It shows everything. Why you would do it any other way, I don't know. Some people choose to. But the survey, for me, is always optimal and it works excellent. There's even a nice little strategy you can use with the patient's eyelashes on that X-ray. Did y'all learn the eyelash method? I'll have to show you the eyelash method. If you put the patient's head correctly in the position, you'll see their eyelashes in the shadow. That means you're in the perfect position. I'll have to show you later what I'm talking about. Just remind me.
Does that work with like people with really short eyelashes?
It does. It does. All right, so positioning here, guys. Oh God.
I know this making my head hurt like for real, Mr. Donahue.
Basically, what you need to write, guys, on the first slide is that you're just going to have the patient sitting upright, preferably. And depending on the portion of the mandible we're focused upon, we are going to utilize different angulations. So the part we desire will be parallel with the IR. The part of the mandible we desire will be parallel with the IR.
So men here just been axial. What are we on?
Axiolateral oblique.
We're on
What, she's asking like
axiolateral oblique mandible.
I forgot who asked me why I moved my head. Like why I took it back.
Oh my
You see how they're picking?
Those are smart TVs, right? You could like cast it from your phone or something.
You might be able to.
Not airdrop, like. But you have to connect to the same Wi-Fi. I don't know if these are
That's fine.
connected.
I'm saying more so like if you do that, then you can like FaceTime someone else's computer. And
You don't want to use the smartphone, but you don't want to.
is it a screen share? Screen share.
Okay, guys, part position. Head will be lateral. No matter what we do for these 3 methods, the head will always be considered lateral. Mouth will always be closed with teeth together. We're going to extend the neck, place the body parallel the transverse axis of the IR. We're going to extend the neck to place the body parallel with the transverse axis of the IR. Now, here's where it gets a little complicated. Depending on what area we want you to visualize, ramus, body, or symphysis, we're going to adjust the rotation of the head slightly to place that area of interest parallel to the IR. So, write these 3 down. If I'm interested in the ramus, I'm just putting the head in a true lateral. That's all I'm doing, first of all. We're not talking about angle yet. This is the rotation of the head. Ramus is gonna have the head in a true lateral. Body, we're gonna rotate the head 30 degrees towards the IR. Symphysis, we're gonna rotate the head 45 degrees towards the IR. That is not talking about the general survey you learned in lab, which once again is the most optimal way to do it overall. But per the curriculum, these are 3 methods depending on what area of the mandible the radiologist wants to see in particular. So ramus, head's in a true lateral. Body, rotate the head 30 degrees. Symphysis, rotate the head 45 degrees. That's towards the IR. Rotating it, not tilting, rotating. It means turning the head. As you can see being done on this picture here, guys, she's turning her head 30 degrees for the body, turning her head 45 degrees for the symphysis. And turning the head is going to cause some distortion in those areas, just to give you a little bit better view of those portions of the mandible. And you'll notice on all 3, using the same angle though, that's a 25 degree cephalic angle. 25 degree cephalic angle on all 3 of those. 25 degrees cephalic angle. Make sure you put a star by this because this is different how you run it in lab. Because in lab we're teaching you the general survey, which is really the superior way to do it.
We did both.
We did this as
Oh,
well.
y'all did? Okay, good. Good. That makes me feel better.
So it's modified this way, but then you're moving.
So what you're going to do basically is you're going to put the head in true lateral, just like we're doing like a regular lateral skull. But then depending on what we're looking at, let's say we want the body, we'll turn the head 30 degrees. If we want the symphysis, we'll turn it 45 degrees. It's just going to distort those areas a little bit more.
Yeah, but then where does the 25 degrees cephalic come in?
That's going to further elongate the mandible at that angle on the tube. So we're combining rotation of the head with angle of the tube. I'll show you what those look like here in a second. It does distort the areas quite a bit. So it's a combination of angle and rotation of the head. I think on the star of your show, as I always say, star of your show.
Is the test that usually everybody does body, or was the?
It's just, everyone just hates doing those things because, I don't know, I think combination of putting the head up and turning it just throws people off. And then of course the angle. Of course, really when it comes to centering, it's easy to find the centering, just find the gonion. It's like a little target on the tip of your chin there, gonion. All right, so for all of them, thankfully that angulation does not change. We're using that 25 degree cephalic angle. It says pass directly through the mandibular region of interest, but one thing you can do that works every time is just put on the gonion. It's not going to make that big of a difference. That's a very subtle change. You can just aim for the gonion. Still make sure you calm it down to an A5-10, but make sure you're not clipping those TMJs. They're still looking at those TMJs. But really the biggest challenge just comes from making sure the head's positioned correctly on this one. That's what gets people the most. Nobody say anything, it's making me hurt. Don't let it hear you. You know, probably just heard me, but.
Don't move.
Don't move. Is my static electricity powering it? Like, okay. Okay. But I like to walk when I talk.
But if you want this to work, you gotta be still.
I like to be static.
Why are you standing there?
Huh?
Did you gotta do the parkway?
Why am I standing here? She said don't move, but really it's working to not move.
Oh.
But I like to pace.
You're standing there because you're looking at the parkway?
Hmm?
You're standing there.
Actually, it's right there. Did you
Can you see the
notice?
parkway on your computer too, or does the same thing?
I can see it on the TVs too.
No, I'm saying like, does it do the same thing like that?
Oh, I see.
Oh, the computer doesn't. See, it hurt me. It hurts talking. You know, you hit frustrations in life, you just gotta power through it sometimes. We're gonna power through it.
You could save yourself some stress.
Because even you
No.
there have to look at the parkway, that's why you're standing.
I appreciate the valiant effort, but
I'm just trying to
still
help
no.
you. I know your blood pressure's really high.
My blood pressure's quite good.
The man can follow.
All right, guys, and this is what it's going to look like right here. This is a regular axiolateral oblique. This is more so like the general survey that you've been doing in lab. By the way, I don't like this x-ray because they're actually, once again, using that old circular collimation, they're cutting off a large portion of the mandible. We can't even see the TMJ. That's not an optimal x-ray at all. But it does show this portion very well. I'm kind of aggravated that Merrill's didn't update this picture. We still do these. You can tell it's a film x-ray because it has the circular collimation. We need to update that picture. Structures shown, region of the mandible. Got that cotton mouth. Mandible, that was parallel. Get that cotton mouth sometimes, your mouth gets dry. You try talking for 2 hours, see what happens to you.
Why the coffee? All turns red.
Evaluation criteria. When it comes to ramus and body, of course, no overlap with the ramus on the opposite side of the mandible. You also want that to be elongated. That says, well, let me take that back. It says no elongation or foreshortening of the ramus or body. No, it is slightly distorted. I kind of screwed that statement. And no superimposition of the ramus by the C-spine. So really, it's basically, evaluation criteria is what am I focused on? If it's just a survey, it's all the mandible. Ramus, I want to see the ramus without superimposition. Body, I want the body without superimposition. Symphysis, I want the symphysis without superimposition. It's all based on what part I'm looking at.
And you do this for both sides, correct?
Actually, you don't have to do both sides. Well, it depends on the facility you work at. Sometimes they just want the side of interest, sometimes they want bilateral.
Okay.
It varies.
But for the test?
For the test, you only have to do the side of interest. The only one where you're required to do both sides would be your nasal bones, because they come in a pair.
I was gonna ask, so yesterday we got an order for the knees, both knees. They ordered everything separate. Is there any way that we can change it?
What do you mean everything?
Like, you know how, like, for the knees, for the AP knees?
Let me go to the next slide so y'all can write well.
For the AP knees, I'm assuming, wouldn't they just order a bilateral knees?
Oh,
and
you
then-
mean, why didn't they just do like a bilateral standing knee? Where was this at?
Yeah, Albany. So my thing
It's
is
probably
like,
just a protocol thing.
oh,
It's just really what the doctor wants, honestly. You're like, well, would it be more efficient to do bilateral? Yeah, it would, but you're kind of at the mercy of what the doctor wants, unfortunately.
so we wouldn't be able to change it.
Depends on where you work.
Oh.
I used to change stuff all the time. Charm my way out of it, but I won't get into that.
What you used to say?
You gotta know how to charm the doctors the right way and
What you used to do?
get what you need.
What you used to do? How you charm?
How do I charm
Yeah,
them?
what you used to say?
Like, what would you
We'll have
have
another
done
class
in
on
that
that.
case?
You just, you get to know them and get to know them personally, and you can subtly suggest what you need, and they'll trust you and do what you need. But if you have a bad reputation, they're not gonna give jack squat. It's just all about getting to know them, and I'm not gonna say anything else.
Okay, so like
Not
yesterday.
kissing up, more manipulation, but you can coax them into making your job easier. Because let's be honest, all right, you're gonna make me go on a whole tangent here now.
You're slithering,
But let's be honest, a lot of these doctors are really stupid.
Yes.
They have no clue what they're doing. They shouldn't be reading these x-rays.
Mhm.
They need more educated people like us to point them in the right direction sometimes. But you got to play the politics right.
Mhm.
I'll say that. And you should advocate for your patient, get stuff simplified when you can, but then you get stubborn doctors that won't do it. Just, you gotta read the situation, read the person, read the room.
So yesterday we had a patient who said her left side was hurting, the left shoulder, but they ordered her right shoulder. And Yanni was on the phone with the doctor, like trying to get it fixed. But what happens if the doctor's just like above them? They're like, no, we're not gonna change it. It says
Well, let me tell you
right.
how I would do this. See, what she did wrong was she asked the doctor instead of just telling them.
Oh.
So here's how I would do it when I would talk to these EC docs. When they would order something ridiculous, I'd be like, hey, so I noticed you ordered an elbow form and hand on this child. So the patient is complaining of just wrist pain. So I'm gonna go ahead and just do a forearm because that's gonna get the entirety of what you ordered. Is that okay? See how I did that? I didn't say, can we abort? I just said, I'm gonna do this because it's gonna be more efficient. Like, oh yeah, that's a great idea, go ahead. It's all in the approach.
I think it's funny when they like ask you a text, like,
I'm a doctor.
It's all in the wording and the approach.
Do they not know about like
No, they don't care. All they see is the money signs and what they think they know best, which they don't. These doctors, they don't learn X-ray. They get, you know what? They get like one class going over X-ray. It's a very generalized version of what you're supposed to order and what you see. But beyond that, they don't learn anything else. You have a superior vast amount of knowledge to this. Even radiologists, they learn very small amounts when it comes to positioning. They mostly just learn how to read the X-rays. So you really have a lot more knowledge than a lot of these doctors have when it comes to the anatomy, the positioning, and all that stuff. Don't let that get to your head, of course. But as I said, you can coax them into getting what you need. It's all about the approach. It's all about playing politics. We'll talk about politics in a later class, but you can play the politics and get what you need. There's an art to it. Okay, what was I even talking about?
This is the only slide that
I used to have
that
some
it
epic
has
battle
data.
with these people on the phone, I swear.
How did you word subtly that the doctor should come and position your elbow patient?
How did I do that?
He's like,
Let me-
my patient was out the window, so I told you that.
Let me think for a second, because I have had to do this multiple times. Trying to think of a scenario in my head.
The GSW victim.
Hmm?
The GSW that had a shattered elbow.
I told you that story, right?
But
Yeah.
You said subtly, so I was wondering how subtle you were with that.
I was not as subtle on that one because I was mad
Mhm.
because we were torturing this poor kid. I basically told the doctor, I said, look, I have taken 3 X-rays. If you're unsatisfied with my work, you're free to come down here and position it yourself and I'll shoot the X-ray for you. He said, okay. He came down. It was worse. He said, all right, I'll just go ahead and take yours. I said, all right.
So you gave him the option.
No, I said, if you want something else, you can come down here and position it because I'm not doing it anymore on this kid. I've tortured him for 3 X-rays. I'm telling you that's the best I can get. If you think you can do better, come down here and do it yourself. Don't be afraid to stand up for yourself sometimes either. They get to be big jerks, and y'all know that. They get really inside their own heads, high and mighty, think they're invincible and superior beings on the earth, and they're not.
Use this too.
Yeah, stand up for yourself.
I think I was in bone clinic one day and they ordered shoulder and they didn't put like what they wanted and I think it was Mary just told them to like just do whatever you want. She's like, what do you want to see? It's like just pick 3 positions. I was like, what the hell?
All right.
So I'm gonna just do the routine then.
Since this is behaving, let's get back on track. For evaluation criteria of the symphysis, that's the tip of the chin, which you can see right here. Look at this tip of the chin area. That's what we're elongating or more in focus of. Same thing, no overlap. Basically, whatever we're looking at, whether it's body, ramus, or symphysis, we're turning the head correctly to prevent the overlap to see it free of superimposition. That's the main point of each of these axiolateral obliques. To free the area of interest of superimposition, to get a better visualization of that part.
Mr. Fung was saying like when we did this, like the Rami, basically your forehead and nose touches, and then you move it a little bit, then your nose and cheek touch the forehead, and then if we do the, what is it, the symphysis, then like the tip of your nose touch the forehead.
Basically, yeah. For that general survey, y'all just remind me with this next week, eyelashes. Can't go wrong with the eyelashes.
Doesn't matter how long or short.
Doesn't.
Real or fake?
Real or fake, it should still work.
Okay.
You know, just put on some.
And some of them
eyelashes so I
fake
can do
ones,
the
some of them
same.
fake ones, I'm almost like, whoa, I gotta step back and you're gonna slap me in the face. You're some super long ones.
That one.
My son has like really long eyelashes, he has big eyelashes.
My son has eyelashes like.
think that's like God's sense of humor. He tends to give boys longer eyelashes.
Yeah, because that's why everybody thinks my son is a big girl because he has long eyelashes and he has big eyes. Like,
You said you don't know if your son is a girl?
What?
What did you say?
I said a lot of people think like if they don't know, they think that my son is a girl because we haven't cut his hair yet and because he has eyes like.
Oh yeah, my mom did that. Let my hair grow out super long before I got my first haircut. That's super curly
But that's
hair.
like in our ritual though. We can't cut it after.
I had like a curly blonde fro. Find that one of my pictures.
And he was not bald when he was born.
We did the SMV yesterday.
Did y'all? So SMV, we do an SMV for a mandible series as well, guys, as you can see by the pretty white screen. We are gonna keep the patient in an upright position. What are we gonna do? Same as we've done for all the other SMVs here, guys. This has not changed. This is the same position. We're putting the head back. We're placing the vertex of the skull flat against the IR. We're making sure the IOML is perpendicular to the floor.
I thought we did SMV.
This is another SMV. This is for the mandible. Yeah. We're gonna put the IOML perpendicular to the floor, but parallel to the IR. It's a great thing to write down. IOML is perpendicular to the floor, but parallel to the IR. But the main thing to get an SMV correct is to make sure that vertex is flat against the IR. And as you know, being the patients at this point, very difficult, hurts your neck. Imagine that your face is busted up and you're having neck and head pain. It's even more difficult. But regardless, we do have to get that head as far back as possible. But let's say a patient can't do it. Let's say they've been in a car wreck, their neck is stiff, and they can only get their head about this far back. Can you still get a pretty good SMV?
Angle the two.
You angle the two, that's correct. Which actually, if you look on the picture, that's what they're doing. Because this lady here does not have her head all the way back, but they're angling the tube into the angle of her head. That will not be optimal, but still give you a pretty good image that's going to duplicate an SMV. There's another option you can do, thinking outside the box once again. Never be like, well, patient couldn't prevent me from getting a good enough image, that's all I can do. You can always take it a little further and optimize that image just by thinking a little bit more critically. And to be the best tech you can be, that's what makes you the best tech you can be. You're not only going to impress your peers and your colleagues, you're going to impress the doctors, and that's how you move up in this field, by showing that you can critically think outside the box. And I keep telling y'all that because I just don't want y'all to fall into that trap of being those techs that just say, oh, that's good enough. Open it up, that's fine, that's all I can do. Good enough. I hate the words good enough. Nothing's ever good enough. You can always optimize further. I'm just on a soapbox today about everything, aren't I? It's because this projector's driving me nuts. But great mindset to have, guys, especially if you want to be the best you can be. And I hope y'all want to be the best you can be. You never want to be mediocre or subpar. You want to be the best. The absolute best. Isn't that right? Okay. Somebody said yes. Okay.
So this is gonna give us the same picture as the regular SMV for the sinus.
Basically, yeah. We're doing it all exactly the same. We're just gonna calm it down to the angle, basically. So, central ray perpendicular to the IOML, unless we're angling to match the angle of the head. They can't get their head all the way back, as you see in this picture right here. But that's still gonna be considered perpendicular because we're matching the angle of the head. Keep that in mind. Centering is gonna be between the mandibular angles, also called the what cell? Those gunions, those gonions. We're gonna bring that collimation way down because unlike the skull, we don't need the whole skull. Who's the star of our show? I hope it's the mandible, which it is. We're gonna collimate down to the mandible. Just make sure you don't cut off the tip of that chin. That's where people make a mistake on that one. So no larger than that 8 by 10 is what you want to aim for. Smaller area of interest. Make sure, guys, by the way, when you do these, even in lab, make sure you help the person sit up. You can get orthostatic hypertension from sitting like that. You get real dizzy and black out. So always remember your patient care as well. I've seen people just leave them there and then they're like, okay, we're done, you can sit up, and like you're trying to sit up, you're like about to pass out. It's kind of rough on you. As you should know by now, if you've all been in this position in lab. Yeah, I remember being in this position for my partner in lab when I was in school. And we were doing the headwork chapter, and I've told y'all how my teacher was like from hell, like she was like demon spawn, which she was. She made us good techs, I will say. But I remember it was during this test out, my partner, she burst into tears crying, freaking out because she forgot everything. And the teacher just sitting there just like scowling at her, like, you better stop crying and figure this out. You need to shut up and get this done. Like she was like being, oh, like I was like, oh my God, I'm sitting there like, oh God, I wish I could help, but I can't do anything, I gotta freeze, I can't say anything. So I knew what she needed to do. I was like, just turn my head a little bit more this way, but I couldn't do it. Like this teacher, she had a hawk eye. She could see if you just breathe wrong. I'm gonna fail you if you help anymore. Like, I saw you glancing at your partner. I saw you giving those signals. She was something else. Connie Young. God bless her soul. I think she's still teaching too. She's teaching in another state now.
Really?
You see Connie Young as a teacher, stay away. Stay far away. She traumatized me.
My mama said not
but-
to get next to you.
But I will give her credit, she made us into some excellent texts, as harsh as she was.
Imagine she's a judge at TSRT.
Oh.
She's not in Texas, so
Is your
I don't
restraining,
give him
We're in luck.
anxiety like
your
that.
restraining order's that big?
it is. All right, guys, structure shown. We're going to see those coronoid and condyloid processes of the rami. That's the main thing we're focused on the SMV here. That's what we see right here, by the way. The condyles and the rami. Kind of looks like a fish mouth a little bit. This reminds me of a fish mouth.
Is it
A
the start of the
bass.
show?
Huh?
They're the start of the show.
They're not distorted. I mean, it's like a regular
The
SMV.
start.
It's
The
just-
start.
Oh, yes. I thought you said, are they distorted? Yeah, they're the start of the show. Yes, they are. Yes, they are. I know I say that a lot, but hey, it sticks. Now, the main thing I want you to look for on the SMV, and this tells you that you have the head back far enough, is that the condyles of your mandible will be anterior or in front of those petrous ridges. That's the main thing you look at. You're gonna see a lot of stuff there, but that one red's the main idea, which I'll focus on. That's for any SMV, by the way, but especially important for mandible, because that's the start of our show.
You said they'd be anterior and what?
Anterior to the petrous ridges.
Thank you.
Yes.
So, pars petrosal and petrous ridges are synonymous?
Correct. Is that up there? Yes, it is. Pars petrosal. Another way to say it. They got a lot of names for those petruses. Pars petrosal.
Select the whole and follow.
I think it looks like a fish mouth. You don't see a fish mouth? Like a bass? Oh, you can hold them by the mouth? Okay. That's what it reminds me of.
Oh, yeah.
No one's been fishing?
Yes, they do.
Or shark mouth. It's like,
The what?
mm,
Coronoid process. So a little hard to see right here, but if you look on the left side, see that little protrusion there? That's the coronoid, so that little sharp protrusion in front of the condyloid process. And they have some fillings, as you can see. Well, on that side at least.
Are those teeth on the medial side of the ramus?
It's not these here?
Yeah, but
Yeah.
more towards the actual mandible. It looks like a triangle, sort of.
How about this right here? That's the coronoid.
Like beside this portion here, there's like this dense area,
I think that's just the mandible superposed on itself, like the rami in the body.
but like just next to where your finger was just at, right there.
Here?
Left.
Here? That's a tooth, yeah.
Okay, so
But
was
that
it-
white portion there, that's the superimposed body in rami.
So that's not the condyloid or the.
Condyloids are down here. Yeah, that's the mandibular, the condyloid processes. The fit into the TMJ.
Yeah.
All right, guys, well, speaking of TMJs, we've got 3 positions of the TMJs we're going to review now. And actually, it's been kind of interesting to me that these have been coming a lot more often in the clinic areas. I've only done one of these my entire career. They're super rare, but apparently they're becoming more common through the clinics. You saw one at Strawberry, I know someone saw one someplace else. But Of course, we're gonna be checking the integrity of those TMJs, making sure that those condyloid processes are fitting into that temporal bone correctly. They're not getting lockjaw or dislocation going on, which does happen quite often. So the ones we're gonna be doing is the AP axial. Two different axial laterals we'll focus upon. We have a regular axial lateral, which is also called the modified Schuler. That should be SCH, by the way, not SH. Modified Schuler. And the axial lateral oblique, or the modified Law. These have been coming up on the registry quite a bit, both of these, so we're gonna make sure we review these pretty thoroughly. ART want to be extra evil and throw these back in there, because they're very obscure.
You just pointed and I almost got you, though.
You almost got me?
Yeah, I didn't do that. Usually I get you when you're in motion, and Jonathan never probably spewed his word. He told me that when he see you, he's gonna say, well, I didn't quite say it like that. I said, yes, you did.
Oh, he was trying to defend himself, but he turned beet red.
I said, open it up. That's the way it's done in the world, right? Talking about, it ain't what they teach you in class. The real world, you gotta open it up.
Yeah, he tried to sell out, but I was like, you're just digging a bigger hole, man.
I said, I'm gonna tell him. I'm gonna tell him. I'm gonna tell him about him.
All right, first one, guys, the AP axial TMJs. So, as always, seated upright being the best way to do it. Posterior skull in contact. Looks very similar to something else we've done, that being the Townes X-ray. Very similar to a Townes X-ray. So we're gonna flex the neck, actually just like a Townes, so that we put the LML perpendicular to the IR plane. So the patient looks nice and awkward and has a triple chin like this lady here.
She mad.
You wanna have their head awkward so you see a double chin. That's the way to do this position correctly. Everyone gets a double chin when you do that position. Yeah, she does look very intense in that X-ray. She's really intensely staring there. It's gonna be, I think it's above glabella. I have to always review these because I've only done these once in my entire career.
Is it similar to the Townes, or is it like the hairline?
You said that's the
These are right
unicorn
here.
horn?
Where is
It's kind of like a unicorn horn. It's similar to a
It's like 3
Townes.
inches above the
3 inches above the nasion. So it's not even glabella at all. I apologize. 3 inches above the nasion is the centering point for this one. Make sure you write that down, because even though it's similar to a Townes, it has different centering. We are going to use a 35-degree caudad angle as well. 35 degrees. It's going to elongate that TMJ area so we can check that dislocation that's going on. Now, let's get my hopes up. It's doing so good. Now, with all your TMJs, no matter what position we're doing, we're always going to do one exposure with the mouth open and one with the mouth closed. But of those two, we always do the closed mouth first. Why do you think we do the closed mouth first? That's a great question. To see if it's dislocated, because if you notice that a TMJ is dislodged, you don't want to have them open their mouth up. That's going to cause a lot more problems. But it may become dislodged as they do the open mouth and then pop back into place. People get crazy stuff with those joints. Have you ever had locked jaw as well? It can be very uncomfortable. Very uncomfortable. I've never had that. I've known people that have had it. That's where your TMJs really just get stuck open and you can't close your mouth. It can be very uncomfortable. Is that pretty funny? Okay. Just making sure. You paying attention? All right. Important stuff. Make sure you know that the closed is done first before you open though, because we gotta check that dislocation. Same thing, guys, smaller area. I'll get your question in a second. 8 by 10 inches at minimum, because we're not focused on the whole skull. Really, the only x-rays where we're focused on the whole skull is the skull cranium x-rays. Everything else should have a tight collimation for those small bones that we're looking at. Question, Jack? Go ahead.
I was just gonna ask if that's considered a trauma view.
Is this considered trauma?
If you're closed mouth.
Is it considered trauma?
Yeah. If
Not
they're-
necessarily. These come in as routines.
Okay.
Because a lot of times, even though people are having TMJ problems, they're not necessarily dislocated, but the bones might be too close together, and then the cartilages become compromised, and you can see that on the x-rays. Think about like with any joint, like we do like even knees, that cartilage starts to degrade and those bones will get closer together and start grinding against each other. You ever hear someone when they chew, their jaw pops a lot? Like my wife has that. We gotta go get her checked out. Her jaw pops when she chews. It's likely because the cartilage has become compromised and those bones are really grinding against each other, which can be very uncomfortable. Yes.
The Towns is 2.5 above glabella. What's
This is
the
3 inches
distance?
above the nasion.
What's the distance between glabella and
They're
inguinal?
about the same.
So it's the
They're
same
just
thing,
being
right?
cheeky. It's about the same, but they want to differentiate, so let's go with what the curriculum's saying. Is it the same? Yes, but we gotta stick with what the book's saying on that.
But we gotta stand up for it.
I'm gonna use what the book says. You're doing so good. Come on.
You're right when you yawned.
I know.
That's trying to be annoying.
Oh, I think it
It's
turned
driving
off,
me nuts.
right?
I know it is.
I think it turned off.
It did, that's weird.
Like the actual.
Trying to keep it together.
10-minute break?
We probably could blow
20.
it up.
Make it 20. Make it
Yeah, 'cause
20.
it turned off. You know, we have
I don't think you turned it off.
Oh, you turned it off?
Yeah.
No, you can't even look at it. There's your headache.
I know I have a headache now.
I'm gonna do balance test because
I'll be
we
on edge. I'll be on edge for this conference next 2 days. So if I can see anything going on, be like, hey, I'll be like hollering at people. No, no, Mr. Donahue,
And
here.
then you're gonna be like,
Let's go get me a coffee right now.
Not the one that's standing up there.
not the one that's standing up.
I don't know what that is.
Are you using a flash drive for your PowerPoint?
Couple? You going hair as hell, shirt, hair as hell.
Mr. Donahue,
Yeah,
are you saving your PowerPoint to a flash drive?
I am, yes. I'm saving it to an online drive and a flash drive, just in case. You never know what kind of issues you're gonna have.
I don't need the flash drive here, cause I'll take it.
Oh my goodness, this girl.
Restart this thing. Go ahead and take a break, guys. I gotta restart all this. 15-minute break.
Make it 20 since you put it through so much torture.